You do not have to declare war on every carbohydrate to improve blood sugar. For many people, the more useful question is not, which entire food group must I remove? It is, what can I add to my meals so glucose enters my bloodstream more slowly, I stay full longer, and the plan becomes easier to follow? That distinction matters because extreme rules often work for a few days and then collapse. A person skips bread, rice, fruit, and beans, feels restricted, becomes hungry, and eventually returns to the same meals without a workable structure. A better approach is to build meals around fiber, protein, unsaturated fat, minimally processed carbohydrates, and portions that match your body, medicines, and activity level. This video will cover 10 foods that may support steadier glucose when they replace less helpful choices or are added thoughtfully to balanced meals. None of them is a cure. None can guarantee that insulin resistance will disappear, and no food should be used as a reason to stop diabetes medication, but several can make a meaningful difference as part of an overall plan that includes movement, sleep, weight management when appropriate, stress control, and medical follow-up. The first three are often promoted online as natural blood sugar remedies. We will separate what is plausible from what is exaggerated. The middle foods are easier to use because they improve the structure of ordinary meals. The final two show why carbohydrates themselves are not automatically the enemy. Before we begin, think about your usual day. What do you eat at breakfast? What snack appears when you become tired? Which meal produces your highest reading? If you use a glucose meter or continuous glucose monitor, those patterns are more useful than a viral promise. Your response to a meal can be shaped by the portion, preparation, sleep, stress, time of day, recent activity, and medication. The goal today is not to hand you 10 new rules. It is to give you 10 tools. You may use only 2 or 3 of them. The best choices are the ones you tolerate, enjoy, can afford, and can repeat. There is also an important safety point. If you use insulin or a medicine that can cause hypoglycemia, such as a sulfonylurea, major changes in carbohydrate intake may lower your glucose enough to require professional dose adjustment. Do not change the dose yourself. Monitor as directed and bring your readings to the clinician who manages your diabetes. One more point before the countdown. A reading that improves after one meal does not prove that insulin resistance has been reversed. Glucose naturally varies, and meters have an allowable margin of error. Look for repeated patterns, not one exciting number, and use laboratory testing to judge longer-term change. Current diabetes standards emphasize individualized glucose goals and active prevention of hypoglycemia, especially among older adults and people using insulin. I am Dr. Richard Kim. Before we dive into the science, please take a brief moment to like this video, subscribe to the channel, and share it with someone you care about. Your continued support allows this channel to grow faster than I ever imagined, and it empowers me to keep producing these in-depth, scientifically grounded health guides for as many people as possible. Thank you so much for being part of this community. Now let us clarify what insulin resistance actually means. Insulin is a hormone made by the pancreas. After you eat carbohydrate, digestion turns much of it into glucose. Insulin helps glucose move from the bloodstream into muscle, fat, and other cells, where it can be used or stored. With insulin resistance, those tissues do not respond to insulin as efficiently as they should. The pancreas may compensate by releasing more insulin. For a time, glucose can remain near normal. As the process progresses, the pancreas may no longer keep up, and fasting or after-meal glucose rises. This is more complex than a locked door that one ingredient can suddenly reopen. Genetics, body fat distribution, physical inactivity, sleep, stress hormones, aging, certain medicines, and other health conditions can all contribute. The liver may release too much glucose overnight, muscles may take up less glucose after meals, fat tissue may send inflammatory and metabolic signals that make the system less responsive. That is why diabetes care cannot be reduced to one spice, one drink, or one cellular reset. The strongest plans improve the whole environment in which insulin works. Muscle activity increases glucose use. Losing a modest amount of weight can improve glycemia for people who have overweight or obesity. Fiber-rich foods can slow digestion. Protein and unsaturated fat can improve fullness. Medicines can target different parts of the problem and protect the heart, kidneys, or other organs. Carbohydrates also differ dramatically. A sugary drink is absorbed quickly and provides little fullness. Lentils contain carbohydrate, but they also bring fiber and protein. A bowl of sweetened cereal does not behave like intact oats, beans, or a measured serving of fruit. Instead of asking whether a food contains carbohydrate, ask how processed it is, what accompanies it, how large the serving is, and what your glucose does afterward. With that foundation, let us begin. Number 1 is fenugreek. Fenugreek is a seed used in cooking and traditional medicine. It contains soluble fiber, which can absorb water and may slow digestion. Small clinical studies and reviews have suggested possible improvements in glucose measures, but the evidence is not strong or consistent enough to treat fenugreek like a diabetes medicine. Fenugreek can also cause gas, diarrhea, nausea, or a maple-like odor. Larger amounts may lower glucose, which matters if you already take insulin or glucose-lowering medication. It can cause allergic reactions, particularly in people sensitive to peanuts, chickpeas, or related plants, and it may interact with medicines. If fenugreek is already part of your cooking and you tolerate it, using a small culinary amount is reasonable. Add it to lentils, vegetables, or a spice blend rather than treating it as a compulsory morning remedy. If you are considering concentrated powder, capsules, or daily medicinal doses, discuss that with a clinician or pharmacist first. Pregnancy, blood-thinning medicine, food allergies, and a history of low glucose require particular caution. The practical lesson from fenugreek is not that a rare seed is more powerful than treatment. It is that soluble fiber can change how a meal is digested. You can obtain that fiber more predictably from beans, lentils, oats, chia, vegetables, and other familiar foods. Number 2 is cinnamon. Cinnamon can make oatmeal, plain yogurt, coffee, fruit, and other foods taste sweeter without adding sugar. That alone can be useful. Research on cinnamon supplements and diabetes, however, has produced mixed results. Some reviews suggest a small improvement in fasting glucose, while effects on A1C are inconsistent. Studies differ in species, dose, duration, and product quality. The National Center for Complementary and Integrative Health states that evidence does not clearly support cinnamon as a treatment for diabetes. Cassia cinnamon, the common supermarket variety, can contain coumarin. Repeated high exposure may be a concern for people who are sensitive to liver injury. Ceylon cinnamon generally contains less coumarin, but Ceylon on a label does not turn cinnamon into a proven treatment. A modest culinary amount is different from swallowing spoonfuls or capsules every day. Sprinkle cinnamon on an appropriate meal because you enjoy the flavor, not because you expect it to act like insulin. If you have liver disease, take medicines that affect the liver, use anticoagulants, or plan to take a concentrated supplement, seek professional advice. Number 3 is broccoli sprouts. Broccoli sprouts contain glucoraphanin, which can be converted into sulforaphane. Sulforaphane has been studied for effects on oxidative stress, inflammation, and metabolism. A human trial using a concentrated broccoli sprout extract reported an improvement in fasting glucose in a subgroup of participants with type 2 diabetes, particularly those with obesity and less controlled disease. That does not mean a quarter cup of sprouts shuts down the liver's glucose production. The trial used a standardized extract, not an ordinary serving from a sandwich. Research on sprouts and glucose remains preliminary, and it is not a reason to replace proven treatment. Smaller trials have also examined broccoli sprout preparations and insulin resistance markers, but these findings require confirmation in broader clinical settings. Broccoli sprouts can still be a nutritious addition. They add crunch and plant compounds with very little carbohydrate. Use them in salads, wraps, or on top of cooked vegetables. But sprouts can carry bacteria such as Salmonella or E. coli because they grow in warm, humid conditions. Older adults, pregnant people, young children, and anyone with a weakened immune system may be advised to avoid raw sprouts or eat them thoroughly cooked. The larger lesson is variety. No vegetable needs to be 50 times more concentrated than another to deserve a place on your plate. A pattern rich in non-starchy vegetables matters more than chasing one compound. Number 4 is avocado. Avocado provides fiber and mostly unsaturated fat when it replaces butter, processed meat, chips, or a large amount of refined carbohydrate, it can improve the balance and fullness of a meal. Fat and fiber can slow stomach emptying and may reduce how quickly glucose rises compared with eating a carbohydrate by itself. But adding half an avocado to an unchanged oversized meal does not cancel the rest of the plate. Avocado is energy dense. For someone working toward weight loss, portion size still matters. A quarter to half an avocado may fit well, depending on the meal and total energy needs. Try adding sliced avocado to eggs with vegetables, using it instead of mayonnaise in a sandwich, or placing a measured amount beside beans and a smaller serving of rice. The useful strategy is substitution and combination. Pairing carbohydrate with fiber, protein, and unsaturated fat often creates a more satisfying and slower digesting meal. Avocado does not soften the blow of unlimited toast or rice. It helps construct a better plate. The carbohydrate amount and quality still count. The American Diabetes Association identifies avocado as a source of fiber and heart-healthy fat that may fit within a balanced diabetes plate. Number 5 is chia seed. Chia absorbs liquid and forms a gel because it is rich in soluble fiber. 1 or 2 tablespoons can add fiber to yogurt, oatmeal, or a measured smoothie. Fiber can support fullness, bowel regularity, and a slower rise in glucose when it is part of a meal. Chia also contains alpha-linolenic acid, a plant omega-3 fat. That is nutritionally useful, although the body converts only a limited amount into the longer-chain EPA and DHA found in seafood. Chia should not be described as directly removing the inflammation that jams insulin receptors. Start with a smaller amount if your usual fiber intake is low. Increasing fiber rapidly can cause bloating, cramps, or diarrhea. Drink enough fluid unless you have been given a fluid restriction. Do not swallow dry chia by the spoonful. It expands when wet and can be a choking or swallowing hazard, particularly for people with esophageal problems. Fiber is most helpful when it is spread across the day and comes from multiple foods. Chia is one option, not a requirement. Number 6 is fatty fish. Salmon, sardines, trout, herring, and mackerel provide protein and long-chain omega-3 fats. Replacing processed meat or a heavily breaded fried meal with fish can support cardiovascular health, which is particularly important because diabetes substantially increases cardiovascular risk. Omega-3 fats are involved in cell membranes and inflammatory pathways, but eating fish does not directly restore an insulin receptor. Trials of omega-3 supplements have not shown that fish oil is a reliable treatment for lowering blood glucose. The benefit of seafood belongs in the broader pattern: high-quality protein, fewer refined carbohydrates when the meal is structured well, and substitution for less helpful fats or meats. Aim for fish regularly if it fits your preferences, budget, allergies, and medical plan. Bake, grill, poach, or use canned fish with attention to sodium. Choose lower mercury options more often. Sardines and canned salmon can be economical, although people who must limit sodium should compare labels. What accompanies the fish matters. Salmon served with non-starchy vegetables and a measured portion of beans, brown rice, or another high-fiber carbohydrate is different from fried fish with chips and a sugary drink. Number 7 is walnuts. Walnuts combine unsaturated fat, fiber, and protein. A small serving can be a useful replacement for crackers, cookies, or chips. Nuts tend to be satisfying, and when they replace refined snacks rather than being added on top of them, they may support weight and cardiometabolic goals. A reasonable portion is about 1 ounce, which is a small closed handful. The original claim that 7 to 10 whole walnuts can turn a glucose spike into a flat line is too absolute. Walnuts contain little available carbohydrate, so they usually have a small direct glucose effect, but your overall response depends on what else you eat. Choose plain or dry roasted walnuts rather than candied, chocolate-covered, or heavily salted versions. Add a small amount to oatmeal or salad, or pair them with a small piece of fruit. Keep the portion visible. Eating from a large bag can turn a planned snack into several hundred extra calories. Walnuts are not a medicine for fasting insulin. Their strength is simpler. They can make a meal more filling and replace an ultra-processed snack with a nutrient-dense one. Number 8 is eggs. Eggs provide protein and contain very little carbohydrate, so they generally produce a small immediate rise in glucose. A breakfast built around eggs, vegetables, and an appropriate high-fiber carbohydrate may produce a different glucose pattern from a large bowl of sweetened cereal or pastry. That does not prove that everyone should eat 2 or 3 eggs every morning. Diabetes increases cardiovascular risk, and dietary advice should consider LDL cholesterol, overall saturated fat, family history, existing heart disease, and what replaces what. An egg breakfast cooked in butter with sausage and refined toast is not automatically metabolically protective. Use eggs as one protein option among fish, poultry, yogurt, tofu, beans, and lentils. 1 or 2 eggs with spinach, mushrooms, tomatoes, or other vegetables may work well. Add a measured serving of intact whole grain or fruit if that fits your glucose target and medicines. If you monitor glucose, test your actual breakfast rather than relying on a universal rule. Compare portions and combinations on similar days. Your meter can help you learn, but do not repeatedly check without a plan for interpreting the results. Number 9 is apple cider vinegar. Vinegar contains acetic acid. Small studies have found that vinegar taken with certain carbohydrate-rich meals can modestly reduce the after-meal glucose response. The effect varies and appears more noticeable with some high glycemic meals than with meals that are already high in fiber and lower in glycemic impact. Calling that a drug-sized effect is misleading. The studies are generally small, short, and not evidence that vinegar lowers A1C enough to replace medication. It can also cause problems. Vinegar may worsen reflux or nausea, irritate the throat, damage tooth enamel, and delay stomach emptying. Delayed emptying is especially concerning for people with gastroparesis, a complication that can already make glucose unpredictable. Vinegar may interact with insulin, glucose-lowering medicine, diuretics, or conditions involving potassium. Never drink it straight. If your clinician says it is appropriate, a small amount used in salad dressing or diluted with food is gentler than treating it as a shot. If you try vinegar, monitor how you feel and stop if it causes burning, swallowing difficulty, worsening reflux, or nausea. It is an optional condiment, not the fastest item on this list. Number 10 is lentils. Lentils make the central point better than any supplement. They contain carbohydrate, yet they also provide substantial fiber and plant protein. Their intact structure means digestion is generally slower than with white bread, sugary cereal, or mashed potato. A measured serving can fit very well into a diabetes meal plan. Lentils do not lower glucose merely because you eat them. They still contribute carbohydrate and can raise blood sugar. Their advantage appears when they replace a similar or larger serving of refined starch, or when they help build a satisfying meal that reduces later snacking. Start with about half a cup cooked and observe your response. Combine lentils with non-starchy vegetables and an appropriate protein or healthy fat. Use them in soup, curry, salad, or as a partial replacement for rice or ground meat. Rinse canned lentils to reduce sodium. Lentils, beans, fruit, oats, and whole grains demonstrate why carbohydrate is too broad a category to use as a verdict. The food matrix, fiber, serving, and meal context matter. NIDDK includes fiber-rich beans, whole grains, and fruit among carbohydrate foods that can occupy the carbohydrate section of a diabetes plate. Now let us connect the 10 foods without pretending they all work equally. Fenugreek, cinnamon, broccoli sprouts, and vinegar have limited or mixed evidence and should be treated as optional additions, not therapies. Avocado, chia, fish, walnuts, eggs, and lentils are ordinary foods that can improve meal quality when they replace refined, heavily processed, or less satisfying options. No single food fully optimizes your biochemistry. Insulin resistance can improve, sometimes substantially, but the degree and timeline differ. Some people with type 2 diabetes can achieve remission, particularly after significant and sustained weight loss early in the disease. Remission is not the same as a permanent cure. Glucose can rise again, and ongoing monitoring remains necessary. Medication is not evidence that a person failed. Diabetes medicines can lower glucose, reduce symptoms, and in some cases protect the heart and kidneys. The idea that prescriptions merely pour more insulin into an insulin-flooded system is inaccurate. Different drug classes work through very different pathways, and many do not increase insulin levels at all. A food plan and medication can work together. As health improves, a clinician may reduce treatment to prevent hypoglycemia or excessive burden. That is a medical adjustment based on readings and laboratory results, not a promise attached to a grocery list. Consider a safer version of the success story often used in videos like this. A 63-year-old with a fasting glucose near 180 does not need a guarantee that eggs, cinnamon, vinegar, and sprouts will normalize A1C in 3 months. That person needs confirmation of the diagnosis, assessment for symptoms and complications, an individualized glucose target, medication review, and a sustainable plan. The food changes may include replacing sweetened cereal with eggs and vegetables, plus a small high-fiber carbohydrate, swapping cookies for walnuts and fruit, replacing part of white rice with lentils, eating fish instead of processed meat, and using cinnamon for flavor rather than sugar. Movement after meals may help when safe. Sleep, stress, and medication adherence also matter. Glucose readings may improve. They may not improve enough. If medication needs to be started or intensified, that is not defeat. It is prevention. Persistently high glucose can harm the eyes, kidneys, nerves, heart, blood vessels, and immune system even when the person feels well. A simple plate structure can make these choices easier. Fill roughly half the plate with non-starchy vegetables, reserve about 1/4 for a protein source, and use the remaining quarter for a fiber-rich carbohydrate such as lentils, beans, intact whole grains, or another option that fits your plan. Add a modest amount of unsaturated fat when appropriate. This is not a rigid prescription, but it gives the meal boundaries. Fruit can also remain part of the diet. Whole fruit generally provides fiber and requires chewing, while juice is easier to consume quickly and can raise glucose more sharply. A small piece of fruit paired with plain yogurt or nuts may work better for some people than fruit eaten alone. Your meter can help identify the portion you tolerate. Meal timing is individual as well. Some people do well with 3 meals, while others need planned snacks because of medicines or activity. Constant grazing can make glucose harder to interpret, but skipping meals may create hypoglycemia or overeating later. Build the schedule around your treatment, hunger, culture, and daily routine rather than copying someone else's clock. Here is a practical plan for the next 2 weeks. First, identify your highest carbohydrate or most processed meal. Change one component rather than rebuilding everything. Replace part of the refined starch with lentils or non-starchy vegetables. Add a protein source. Keep the portion measurable. Second, improve one snack. Use a small handful of plain walnuts, plain yogurt with chia, vegetables with a suitable dip, or another option that matches your plan. The key word is replace, not add. Third, choose a breakfast experiment. Try eggs with vegetables or oatmeal with chia and nuts, rather than assuming one breakfast is best for everyone. Check glucose according to your clinician's instructions and compare patterns. Fourth, use cinnamon, fenugreek, broccoli sprouts, or vinegar, only if you enjoy them and they are safe for you. Do not begin all 4 at once. If a symptom or glucose change occurs, you need to know what caused it. Fifth, add movement. A 10 to 15-minute walk after a meal can help some people reduce the after-meal rise. If you have chest pain, severe neuropathy, foot wounds, dizziness, or significant balance problems, ask for a safe alternative before starting. Sixth, review beverages. Sweet tea, soda, juice, flavored coffee, and energy drinks can add rapidly absorbed carbohydrate without much fullness. Replacing them may produce a larger benefit than any spice. Seventh, protect against low glucose. Know your symptoms and your treatment plan. Shaking, sweating, hunger, confusion, weakness, or unusual behavior can signal hypoglycemia. Severe symptoms, inability to swallow, seizure, or unconsciousness require emergency treatment. Eighth, track enough information to be useful. Record the meal, portion, medication timing, activity, and glucose result. One number is not a verdict. Patterns across several comparable days are more informative. Ninth, ask for the measures that matter. A1C estimates average glucose over roughly the previous 2 to 3 months, but targets are individualized. Blood pressure, cholesterol, kidney function, urine albumin, eye exams, and foot care also belong in diabetes management. 10th, choose a plan that you can continue. A list that requires unusual ingredients, daily acidic drinks, and perfect behavior is unlikely to last. A plate built from familiar foods can. There are circumstances in which dietary experimentation should wait for medical advice. Contact your healthcare team promptly if glucose remains very high, you have unexplained weight loss, excessive thirst, frequent urination, vomiting, abdominal pain, deep breathing, confusion, or severe weakness. These can indicate dangerous hyperglycemia or another illness. Likewise, repeated low readings require review. Older adults are especially vulnerable to falls, heart rhythm problems, and cognitive effects from hypoglycemia. The 2026 diabetes standards emphasize individualized goals and reducing hypoglycemia risk, particularly for people using insulin or treatments that stimulate insulin release. This video is educational. It cannot diagnose insulin resistance, prediabetes, or diabetes, and it cannot tell you how to change medication. Fenugreek, cinnamon supplements, and vinegar can interact with treatment or cause side effects. Discuss concentrated or daily medicinal use with a qualified professional. NIDDK similarly advises discussing supplements with a healthcare professional because evidence for specific herbs and spices remains unclear and interactions are possible. The most important truth is also the least dramatic. You can eat carbohydrate and improve blood sugar, but the type, amount, combination, timing, and your overall health determine the result. Use lentils to replace part of a refined starch. Use walnuts to replace a processed snack. Use avocado or fish to improve the fat and protein quality of a meal. Use chia to add fiber. Use eggs as one breakfast protein. Treat cinnamon as flavor, sprouts as a vegetable, fenugreek as an optional culinary seed, and vinegar as a condiment. Then build around the factors that consistently matter: appropriate portions, regular activity, adequate sleep, weight management when indicated, medication adherence, and follow-up. Do not aim to fix your blood sugar in a few days. Aim to create a week in which more meals support your goals than work against them. Then repeat that week. Sustainable improvement is rarely one dramatic cellular switch. It is a collection of ordinary choices, adjusted with real glucose data and professional guidance. Tomorrow morning, begin with one change. Tomorrow evening, look at what happened. Keep what helped, revise what did not, and bring the pattern, not just the promise, to your next appointment. That is how food becomes useful, not as a replacement for medicine, not as a cure, and not as a source of fear, but as one of the daily tools that helps you manage diabetes with more control and less confusion.